Let's discuss respiratory distress syndrome, also known as RDS. When an infant is premature, they may have surfactant deficiency, which leads to low lung compliance. This, in combination with an overly compliant chest wall, can lead to difficulty breathing for the baby. This photo outlines problems that may be encountered, including alveolar consolidation, atelectasis, and hyaline membrane formation. Lack of pulmonary surfactant leads to atelectasis. This decreases the lung compliance, compromising ventilation and oxygenation. Pulmonary vasoconstriction results, and blood bypasses the lungs via fetal pathways. Blood bypassing the lungs leads to lung hypoperfusion, lung ischemia, and decreased lung metabolism. The cycle continues and respiratory distress is the result. The baby with respiratory distress may present with tachypnea, low oxygen saturations, tachycardia, apnea, retractions, nasal flaring, cyanosis, grunting, and crackles. Blood gases may reveal an acute respiratory alkalosis or an acute respiratory acidosis. This is a chest X-ray of an infant with RDS. Note the whiteout of the lungs due to atelectasis and lack of ventilation. In this case, we describe it as a ground glass appearance. We need to make special resuscitation considerations for the preterm infant, which include warming the room, using a chemical warming mattress and polyethylene bag, and starting with 30 to 40% oxygen and adjusting based on our saturation table. Apply the pulse oximeter. Evidence shows that prophylactic CPAP of 4 to 6 centimeters of water pressure is also helpful. If giving positive pressure ventilation, aim for a PIP of 20 to 25 and a PEEP of 5. Early surfactant delivery may also be needed, as well as gentle handling. This is an example of an X-ray before and after surfactant delivery. Note the improved aeration of the lungs on the right. Speaking of surfactant, you'll want to be familiar with the dosing for Infisurf and Curasurf. CPAP may be used at 5 to 9 centimeters of water pressure via a traditional CPAP or bubble CPAP. We may also use the high-flow nasal cannula at 4 to 8 liters per minute and wean down the flow as needed when the baby improves. If the baby requires mechanical ventilation, we set the tidal volume to 4 to 6 mL per kilogram, a rate of 20 to 40, PEEP of 5, inspiratory time of 0.25 to 0.5, and an FiO2 to keep sats 85 to 95%. If peak inspiratory pressure is increasing at 30 or greater on conventional ventilation, it might be time to consider high-frequency ventilation. The starting point would be to set the mean airway pressure 3 above the conventional map on the conventional vent, a rate of 9 to 12 Hz, an I time of 33%, and an amplitude for chest wiggle to the umbilicus. Thanks for joining me today, and make sure and watch the videos in modules to increase your knowledge.